Bismillah ar-Rahman ar-Rahim. My name is Professor Arshad Chohan. I am Professor of Gynaecology and working at Lahore. I am grateful to the organizers of this conference on rheumatology for giving me this opportunity to speak on this forum. I am especially thankful to Professor Tafazil for giving me this chance and asking me to speak here. It is a very interesting subject because rheumatoid arthritis is a disease of young age, and it causes the chronic autoimmune inflammatory disease of synovial joints with a preponderance, with the female preponderance in a significant ratio. Though it's a disease of joints, it also involves the other organ systems as well. And when it complicates the young women, there is a likelihood of rheumatoid arthritis coming in combination with pregnancy. So it becomes very interesting that how the pregnancy would alter the course of the disease and how disease or its treatment may have an influence on pregnancy. The behavior of rheumatoid arthritis varies in pregnancy in different patients. Interestingly, it improves in certain patients during pregnancy, particularly in the third trimester, and sometimes in the immediate postpartum period. And in others, it remains active, though in some cases, it can worsen its situation. Now, how and why pregnancy has a variable relationship with rheumatoid arthritis? We need to understand the basics behind it. Pregnancy itself, the content of pregnancy comes 50% from the wife and 50% from the father. The 50% component coming from the father is a foreign material for the woman to let it retain in the uterus for some time. Therefore, we call pregnancy a graft. And in some women, the graft is happily accepted, and in others, it is rejected when the miscarriage occurs. That means that pregnancy involves immunomodulation to allow the pregnancy to stay as a graft within the uterus till the baby is mature. If that immunological variation does not occur, that means that pregnancy will be lost, and a vast degree of immunomodulation or change have been noticed at various levels during pregnancy. Because the pregnancy is associated with immune modulation, rheumatoid arthritis is an immunological disorder. So certain immunological changes occur for the sake of pregnancy. They are beneficial for the rheumatoid arthritis disorder, and the patient's symptomatology improves or the disease goes into remission. The drugs which are used in the treatment of rheumatoid arthritis, which may be used during pregnancy, whether they have no effect on the baby or they have effect on the baby in the form of any side effects or in the form of congenital malformations, or do they have any effect on the mother during pregnancy, that's the topic of discussion today. These drugs are divided into three categories. One is anti-inflammatory disease. Number two, disease-modifying anti-rheumatic drugs. We commonly call them DMRD. And then there are immunological modulators. These are the drugs which will be discussed in this talk. What is the objective of treatment when we are giving anti-rheumatic drugs? We want to optimize the disease control before conception. That is the first objective. Number two, we want to maintain a stat control of the same level or a balanced control of the disease throughout conception, using different medicines throughout the pregnancy and lactation. At the same time, we do not want these drugs to cause any harm to the baby or the mother. For that, we need to understand what are we talking about in relation to drugs which are consumed in pregnancy? FDA has given a clear-cut classification of drugs into A, B, C, D, and X groups. A means that it has been used on a human and no significant side effects have been noticed. B is used on animals with a wide safety margin. C, when the drug would cause side effects to the baby but not congenital malformations. D, the drugs cause congenital malformations. And X is lethal malformations. And drugs falling into X category are generally contraindicated, rather absolutely contraindicated in pregnancy. They cause lethal malformations. So we are going to see which group has got what kind of side effects in pregnancy. But before we enter into discussion of teratogenesis or congenital malformations or drug use, we need to understand the embryology. And embryology says what is the role of nature, how nature is protective for the baby from the drugs, from the effects of these drugs. Number one, the organogenesis, fetal part formation, begins 7 days after missing the menstrual periods, which means the woman is given sufficient time to realize that she may be pregnant and she should stop or change her medication before the organogenesis begins. Number two, major organ formation is complete by 10th week of pregnancy, and minor finishing continues till 16 weeks of gestation. Hence, the congenital malformation would occur. If you look at this slide, it says that drugs consumed during luteal phase, that means from the day 15 of menstrual cycle till the next menstruation, when actually the fertilization occurs and implantation occurs, but the patient does not know that she is pregnant. Second half of menstrual cycle is called luteal phase. That is the time when woman is not aware about the pregnancy, and teratogenesis does not occur during this process, and this safety continues till the last taken medicine is cleared from the body within 7 days after missing the date. That means woman is given an opportunity by nature that if she takes the drug in luteal phase when she does not know she is pregnant, it will not cause teratogenesis. And rather, it will give additional 7 days after missing the date. So if she is taking any medicine, she should stop it or talk to her doctor and get it changed before the organogenesis begins. Consumption of drugs after 16 weeks is commonly associated with some kind of adverse effects, but not the congenital malformations. What is important? There are two things which are important here. Drug clearance time. Whatever drug you are prescribing, how long will it take to clear from the body which will not affect the formation of the baby. Number two, what's the role of hyperemesis of pregnancy in prevention of teratogenesis? Nature is always in favor of the mankind. It prevents the formation of abnormal babies, and it prevents the birth of abnormal babies to reduce the individuals in the society who are not able to take care of themselves. Hence, what is the purpose of keeping hyperemesis in the first 16 weeks of pregnancy? The purpose is the woman who is not in contact with the doctor, she is stopped from eating anything in shape of nausea, vomiting, and hyperemesis. The moment she conceives, she develops hyperemesis and she is kept away from eating things. Among them, there may be a drug which may be a component of the food which may cause congenital malformation. So that is a protective role of nature from preventing the teratogenesis. So once woman completes her 16 weeks, one nice morning, the hyperemesis goes away and woman starts eating whatever she wants to eat. Hence, those who are prescribing medicines, they should understand what is the time when the teratogenesis will occur, and particularly the drugs which are used for the treatment of rheumatoid arthritis. Some of them have got teratogenic effects, and that is the purpose of today's talk. This diagram actually shows you that in the first 2 weeks, when that's the primarily from the time of fertilization till missing a date, there is no organogenesis and there is no specialization of the tissue, hence there is no congenital malformation. And the major organ formation that includes the CNS, CVS, that happens in the month after missing the date. Once 16 weeks complete, then the major organs are formed, and generally the midline union, which is cleft palate and cleft lip, they are related to the teratogenic insult at between 12 and 16 weeks of gestation. Now, coming to the drugs, I said there are three groups. One is anti-inflammatory drugs, the second is disease-modifying agents, and others are the biological modulators. Non-steroidal anti-inflammatory drug is readily available, non-expensive, in the reach of everyone. It is not teratogenic, but it is associated with certain effects to the baby. Used before 24 weeks actually contributes to miscarriage. Used in the last trimester is associated with premature closure of the ductus arteriosus. Pulmonary hypertension, oligohydramnios, and inadequate lung development, and sometimes, rarely, fetal death may be associated with it. Generally, it is safe in small dosage, but regular usage has a potential to cause premature closure of ductus arteriosus, which would have cardiac vascular effects. Glucocorticoids is most widely used drug during pregnancy. Betamethasone and dexamethasone are the drugs which we use for the lung maturity for a shorter duration. But when they are given in a longer dosage, there is a risk of adrenal crisis at the time of stress. Hence, the women who are on long-term use of corticosteroids, they would need bolus corticosteroid parenterally at the time of labor, particularly, and then they are very good drugs when there is flare of the rheumatoid arthritis. They bring a rapid relief in that situation. The stress dose is 50 to 75 milligrams of hydrocortisones or methylprednisolone, which you want to give. It should be given on the day of the procedure and quickly tapered over 1 to 2 days when we want to eliminate the chance of stress. Then the disease-modifying drugs, hydroxychloroquine is widely used drugs, and we have a lot of experience with this drug for the treatment of malaria. This is not a teratogenic drug. It is safe in pregnancy and can be used throughout pregnancy with a very minor side effect of low birth weight babies or preterm deliveries. Otherwise, it is not associated with fetal death, spontaneous miscarriage, or any other congenital defects. Sulfasalazine is another safe drug which has a placental passage, transplacental transport, and same levels are attained in the fetus as they are in the mother, except slight transient neutropenia in the baby, which resolves spontaneously within 6 weeks after birth. It has no other effects on the baby, so it can be safely used. But folic acid supplementation is recommended in these patients starting from preconception to throughout pregnancy. Azathioprine falls in category D, the drug which has been spoken about a lot in the literature. This drug is not safe in pregnancy, and it only be used when there is a dire need to use, or the usual is the therapy is not effective. It causes congenital malformations, in shape of occipital and cephalocele, sternocleidomastoid abnormalities, and congenital cataract. Methotrexate, the drug which is very effective in treating rheumatoid arthritis in non-pregnant state, it falls into the category X. Not only it causes teratogenesis, it also takes long time to clear from the body. Hence, it is absolutely contraindicated. The person using methotrexate who is likely to get pregnant should use contraception. Number two, if they want to conceive, they should try to conceive after a minimum of 3 months of stopping the therapy. And if somebody conceives while taking methotrexates, it is an indication for termination of pregnancy. Well, it should be taken seriously to terminate the pregnancy. Therefore, if we are prescribing methotrexate, the couple should be advised to use contraception. And in case of a pregnancy, a termination would be recommended. Even more serious are the things about leflunomide. It belongs to category X, and it has more side effects than methotrexate, and it takes much longer to clear from the body. For example, the long half-life of 14 to 15 days may take up to 2 years to completely clear from the body. Cholestyramine washout procedure is recommended if we really want to make sure that it is cleared from the body. 8 gram is given 3 times daily for 11 days, and plasma levels are checked 2 weeks apart, and the level should be really below the cutoff level. If she wants to conceive, she should be allowed to conceive 3 months after elimination of the medicine from the body, and the patient must be clearly counseled about. The biological disease modifying anti-rheumatic drugs, they are parenterally administered antibodies. They are not used as first line in pregnancy. They are used in patients where the first line is not effective, or patient is not getting relief. But one must make sure that women they do not conceive when they want to use biological modifying drugs, because most of them have got teratogenic effects. Tumor necrosis factor. This is indicated in patients who are not responding to methotrexate. And it is not very rarely used as a first line when there are poor prognostic factors in the patient. Therefore, the next drug is rituximab. I don't know how to prescribe, how to pronounce these medicines, because we are not using them very often. But still, this is used where the tumor necrosis factors are not effective alone. This drug is used in combination. And animal studies are limited in this case, and so far teratogenic effects have not been described. But the care is recommended, and at least 12 months should elapse between this therapy and the next conception, because the studies are only on animals and its effects, teratogenic effects, are not clearly defined. So care must be taken while prescribing these drugs. Abactacept, it is a class C drug. If given at elevated doses, there were alterations in the immune function noted. And at the moment, we cannot say how far this drug is safe. If it has to be used, contraception must be advised, and this drug should not be used set alone. tocilizumab. This drug was approved in 2010 for the treatment of rheumatoid arthritis. It is recommended alone, approved alone, or in combination with methotrexate. It increases the risk of miscarriage. Still, these drugs are in a trial and animal studies are going on, and they are not recommended to be used alone in a woman who is likely to get pregnant. The contraceptive advice should be there. Tofacitinib. This drug has demonstrated congenital malformations in the animals, and in that is in much higher dose that where it is used in the human. So coming towards the conclusion, if you want to prescribe drugs in relation to lactation, non-steroidal anti-inflammatory drugs, corticosteroids, hydrochloroquine, sulfasalazine are all very safe in lactating women. Methotrexate, leflunomide, azathioprine are contraindicated in lactating mothers. And biological modulators, we do not have adequate data to say whether they should be used or they should not be used. I would say when prescribing these medicines, it is better to avoid lactation than letting them lactate. The last slide says that disease modifying agents in case of rheumatoid arthritis are the need of the patient, because the patient is suffering and she wants to have a relief from the disease if by chance it coincides with pregnancy. The drugs which are of the known safety, ultimate effort should be made to use those drugs, and the disease control is better established in the preconception period, and during pregnancy the drugs should be used which are of known safety, and they should be used in the minimum effective dose, and a combination of drugs should be avoided. Where there is exposure to the category X medicines, it is always better to counsel the patient in detail with the gynecologist and with the geneticist to reach at a conclusion whether that pregnancy can be continued or termination should be offered. It is always better to offer termination to those where there is a potential risk for lethal malformations. Thank you very much, ladies and gentlemen.